Shall I know?
Okay, thanks. So I hope the slides visible to all of the moderators and panelists. It is visible?
Yeah, I can see the
Yes, sir.
protectionist prevention slide
Okay.
here.
Yeah. Okay, great. So, we are live now. So we'll start. So very good evening to all of the doctors who have joined across India for today's discussion on the cardiac on the cardiac colloquium is basically a platform where a different key eminent cardiologists comes together and have discussion on the very key points into the management of the cardiovascular. So for the today's program, I welcome Dr. S.K. Agrawal, sir, who is our moderator for today's cardiac colloquium. So I welcome on the behalf of the MQ, sir, and all of the delegates who are watching across India. Welcome you, sir. Followed by this for the today's experts panelist, we have Dr. Amresh Kumar from the HISOD Cardiology Department from the Bareilly, Dr. Anshuman Gupta, Assistant Professor from the DMC Ludhiana, and Dr. Ashok Kal sir from the Jindal Institute of Cancer and Cardiac Research from the Hisar, Dr. Ganesh sir, who is a senior consultant cardiology from the Medanta, Lucknow. And lastly, Dr. Ravi Kumar sir, who is a DM cardiologist from the Medicover Hospital from the Visakhapatnam, sir. So this is out of the today's a great panelists we have for the today's discussion. And the today discussion is all about on the hypertension and diabetes, talking about is there any hope? So to proceed that, I invite Dr. S.K. Agrawal sir to take the today's session ahead.
Okay. So thank you so very much, MQ, for your kind invitation. And I am joined by the five eminent personalities across India from Bareilly, Lucknow, and of course, Visakhapatnam and others. So hope we are going to have a good discussion. So basically what we are going to do that I will present some slides on ACE inhibitors and ARBs in hypertensive and diabetic subsets, and maybe in combined subsets, and how the ACE and ARBs compare to each other. Then maybe we can have the expert opinion from all the panelists in some questions which we have formatted over here. So can I have the first slide, please? So basically, we are the diabetic capital of the world. And if you see the prevalence of diabetes is rising rapidly across the continents. Okay. So in 2017, there were approximately 426 million people suffering with diabetes. And in next 30 years or so, the number is likely to increase by 50%. But the problem is in the Southeast Asia, in our country, that where as of now in 2017, if you see the figure, it states that there were 82 million people with diabetes, especially in our country. But this number in the same duration of 30 years is going to double. So on a global, I will request others to please to mute themselves so that there will not be a disturbance during the presentation. So globally, the prevalence is going to increase by 50% in next 30 years, but in Southeast Asia, it is going to double. So already we have a very high proportion of almost 10% of the patients are diabetic in our country, and another 10% are approximately pre-diabetic, and this number is going to double in the next 20 years or so. So that is how we have the dubious distinction of having the diabetic capital of the world. And we all know that diabetes is a serious risk factor for cardiovascular disease. Next slide, please. Diabetes, when it is combined with hypertension, becomes a more serious concern because of certain common risk factors like genetic predisposition and obesity, ultimately leading to the insulin resistance coupled with the dyslipidemia. And then we have the micro and macrovascular complications. Macrovascular complication, of course, starts with the atherosclerotic plaque in the different arterial system, while the pathogenesis for microvascular complication remains a little complex, and that involves the endothelial dysfunction, the vascular inflammation, the vascular fibrosis, and of course the arterial passive remodeling. And all these factors ultimately combined leads to the microvascular complications. And that is how we develop the cardiovascular and renal disorders, leading to poorer prognosis in patients who are diabetic, who are hypertensive, and especially in those who have both these conditions coupled with the dyslipidemia and other things. Next. So this becomes very, very important for us to understand what medications can improve prognosis in these subset of patients. We are very well aware that people with diabetes are at very high risk of cardiovascular disease. There is almost twofold increased risk for uh, coronary artery disease and heart failure. Almost more than half of the patients with diabetes die of the cardiovascular regions, and more than one third of the patients with diabetes ultimately have coronary artery disease. So that is a serious number. We have highest number of diabetic population in our country, and then majority of these patients will die of the cardiovascular disorder. So probably we need to strike the diabetes and hypertension much more seriously in a better way. Next page. If you see the different risk factors responsible for the death over the population attributable risk factors, if you see the hypertension is the most important risk factor responsible for the mortality, followed by, of course, the tobacco use and the high blood glucose, physical inactivity, obesity, and high cholesterol. So the other 4-5 risk factors which are responsible for majority of death of the general population. So, and good thing is that all these conditions are to a large extent preventable and they are reversible. So if we approach for these risk factors in a proper way, then probably the mortality can be reduced in a significant way in general population. Next. Data from the UKPDS observation study, if you see, there is a direct and linear correlation between the HbA1c level and, of course, the cardiovascular outcomes. So if you reduce the HbA1c level even by 1%, there is significant reduction in the fatal and non-fatal MI by 14%, in fatal and non-fatal stroke by 12%. There is a significant reduction in the amputation and death from peripheral vascular disease by 43%, by just 1% reduction in the HbA1c. And similarly, there is a significant heart failure reduction by 16%. So meaning to say, as the HbA1c goes up, the chances of adverse outcome also becomes higher and higher. A reversal of these HbA1c to a normal level or to the lower side is associated with the improved prognosis across all the spectrum, across all the major adverse cardiovascular events. Next. As far as the hypertension is concerned, even a slight reduction in the systolic blood pressure is associated with improved outcome, and this has been shown in not 1, 2, or 3 trials, but over the past many decades across the spectrum. All the trials have shown that reduction in the systolic blood pressure, even to a minor degree, is associated with improved outcome, as is seen in this trial from the HOT trial, SHAPE, the UKPDS, the IDNP trial, and many others have shown this data. So reduction in the HbA1c and reduction in the systolic blood pressure both are associated with improved cardiovascular morbidity and mortality. Next. So is there any hope? How can we improve the prognosis in these patients? Yes, there is. So we had very good trials with the ACE inhibitors and ARBs, especially in post-MI patients who had heart failure or who had poor LV ejection fraction less than 40%. In the form of like SALT trials, say Barrett, RACE, SMILE, and many other even post-MI patients where LV dysfunction was not there, but like GC3, ISIS4, and Chinese trials also. In general population who don't have LV ejection fraction on the lower side, who do not have earlier myocardial infarction really, but who are at high risk. Also, we have good trials like the HOPE and Europa, and where we have seen that the ACE inhibitors were very, very significantly associated with reduction in the major cardiovascular events. Next, please. So we'll take up the 2 of these important large trials, HOPE and Europa, one by one. So HOPE study was like, it was a large randomized trial, included 9,297 patients. And patients enrolled in the HOPE trial were really high-risk patients, like over more than 55 years of age with evidence of muscular disease, or those who had diabetes, plus one other major cardiovascular risk factor. So HOPE study was a large study. And then there was HOPE sub-study that was into the patients who had diabetes, and HOPE 2 extension was there, like when the HOPE study completed, further extension and follow-up of up to 7.2 years was done, and then the results were analyzed. So let me have the results. Next. If you see the ramipril group, 10 milligram versus placebo group, equally divided, 4,600 patients. And it was a high-risk category patients, as I told you. So half of the patients had hypertension, more than 1/3 has diabetes, almost 80% of the patients had coronary artery disease in the HOPE trial. And significant number of patients were, of course, having the peripheral vascular disease, like 42 to 44% in the ramipril and placebo group, respectively. So it was a really high-risk category where the 10 milligram of ramipril was compared with the placebo. Next. And what we noticed, if you see the primary composite endpoint, that is the fatal and non-fatal stroke and cardiovascular death, MI, fatal and non-fatal stroke and myocardial infarction. So what we noticed that ramipril 10 milligram in comparison to placebo was associated with a significant 22% reduction in the primary composite endpoint. And even at 1 year, there was a significant 15% reduction in the primary composite endpoint. And there was an absolute 3.8% reduction in the primary composite endpoint. So that was a large figure, large reduction in the into the adverse outcome with the use of ramipril 10 milligram in this high-risk population HOPE trial. Next. If you see the HOPE sub-study, means patients who had diabetes also, then also we found that there was a significant improvement in all major adverse cardiovascular endpoint, whether you take the composite endpoint or you take the individual endpoint. So in sub-study, HOPE sub-study in patients, high-risk patients with diabetes, the primary outcome was reduced by 25%, as you can see in this study, in comparison to the 22% in the HOPE trial. There was a significant 24% reduction in the all-cause mortality, 22% reduction in the myocardial infarction, 33% reduction in the stroke, and cardiovascular death was also reduced by 37%. Meaning to say, people with diabetes or without diabetes, they all showed a significant reduction in the major adverse cardiovascular event in HOPE and HOPE sub-study. Next, please. When you talk about the HOPE extension up to 7.2 years, again, if you see the data in HOPE trial versus HOPE extension trial, it was matching with the two components. So even after the completion of trial, when the patients were followed up for further period up to 7.2 years, again, the composite endpoints were reduced significantly as in the original HOPE trial. And another important finding, what was noticed was that new onset diabetes was also reduced significantly in HOPE and HOPE2 extension. So that is how we came to know that the ramipril in a good dose of 10 milligram is associated with a improved outcome in high-risk subset of patients who were enrolled in the HOPE trial. Next, please. So HOPE guidance, what you see here. So there is a direct dose-dependent effect of ACE inhibitors on the RAS system. We all know that the ACE activity is basically two types. Low ACE activity is in the plasma and high ACE activity in the plaque or into the vascular subendothelial compartment. So HOPE data showed that there was a 3.8% absolute risk reduction that culminated into 26 NNT over 4.5 years as far as the primary composite endpoints were concerned. Wide range of patients with vascular disease were enrolled in this trial, and these were really high-risk patients because there was a 4% annual event rate. Now you see the plasma, the low ACE activity is in the plasma, and if you give the ramipril at whatever dose, 2.5 or 5 or 10 milligram, you will have some reduction in the circulating plasma ACE activity, and that will be manifested by antihypertensive efficacy of the ACE inhibitor ramipril. But if you really want to have a proper anti-atherogenic property, if you want to have a plaque stability property, and if you want to have a direct plaque ACE inhibition, then 2.5 milligram is not sufficient. This activity can be achieved only by 5 milligram of ramipril or more specifically by the 10 milligram. So for having an anti-atherosclerotic effect, probably we need to have a higher dose of ramipril in the recommended dose of 5 or 10 milligram, preferably 10 milligram. Next, please. So inhibition of atherosclerotic plaque is there are multiple mechanisms involved how the ramipril or the ACE inhibitors actually improve the anti-atherosclerotic property. So when we give the ramipril, so what happens that it blocks the production of angiotensin 2, and because of the decreased angiotensin 2, you have local mediators are also reduced, as well as the plaque ACE activity is reduced, as we have discussed just now. When the local mediators are reduced because the suppressed angiotensin 2 activity, you have lesser thrombosis because the PI1 inhibitor is reduced. We have lesser inflammatory markers like VCAM, ICAM, and cytokines. And similarly, there is lesser endothelin, so there is less vasoconstriction. On the other side, because of the ACE inhibition, you have increased levels of the bradykinin and nitrous oxides leading to vasodilation. Then there is a reduced growth factors and proteolysis leading to vascular region positive remodeling, and lesser chances of plaque rupture. So multiple pathogenetic mechanisms are involved basically. That is how the endothelial function is improved. Lesser chances of thrombosis is there with the use of ACE inhibitors, and not only that, lesser inflammation and proper vasodilation is achieved by the use of ACE inhibitors, as has been demonstrated in different trials. Next. If you see the effect of ACE inhibitor on the carotid intima media thickness, which reflects the regression or slower progression of the atherosclerotic plaques. So you can see from the HOPE secure study that there was a 37% slower progression of the CIMT with the use of ACE inhibitor ramipril in comparison to placebo. Next, please. Coming to the Europa trial, so like HOPE was into the high risk patients who are at higher risk of having major cardiovascular event. Europa was somewhat in the stable coronary artery disease patients who did not had heart failure. So here the perindopril 4 to 8 milligram was compared with the placebo. Baseline characteristic, you can see the lesser number of patients were hypertensive and diabetic in the Europa trial, and lesser number of patients had the CAD. Next, please. So it was more of a stable CAD patient. So in this trial also, as we have seen in the HOPE trial, there was a 22% reduction in the primary composite endpoint. The Europa trial showed that the use of perindopril 4 to 8 milligram was also associated with a significant 20% reduction in the primary composite endpoint, which was similar in the two trials. Next, please. Now, if you compare the HOPE published in 2000 and Europa 2003, so we can see this is a little bit cumbersome slide, but what I want to highlight over here is that the results of these two trials were matching with each other. There was a significant and direct reduction in the primary composite endpoint, as well as there was a significant reduction in all the major components of the primary composite endpoints, be it the stroke, be it the MI, be it the fatal or non-fatal cardiovascular death, of course. Next, please. So if you see the ramipril and perindopril, if you compare the HOPE and Europa, so HOPE enrolled 9,200 patients. Europa had 1,200 patients. Europa was relatively a lower risk profile group. So because diabetics were 38% in HOPE, 12% in the Europa trial, hypertensive were 47% in the HOPE trial. Only 27% of the patients were hypertensive in Europa trial. Peripheral vascular disease are very common in HOPE trial in 42% of the patients, but in only 7.1% of the patients in the Europa trial. Previous stroke was in 10.8% of the patients in the HOPE trial, but only in 3.4% of the patients in the Europa trial. Europa trial was primarily carried out in the Europe, while the HOPE was into the North and South America, and of course into the Europe. Mean blood pressure was almost comparable into the two studies, and so that is how the things were like. And NNT was over 3.5 years was 26 in the HOPE trial, and NNT over 4 years was 50, because it was a low risk group in Europe. So obviously the annual event rate was also on the lower side. So NNT was a little higher, but definitely the perindopril did show that it is as efficacious as the ramipril, and ACE inhibitors are a good drug for preventing the major adverse cardiovascular events. Next, please. So coming to the LIFE trial, which was like one trial which evaluated the losartan versus atenolol in patients who had essential hypertension plus LVH on ECG. So it was again a double-blind randomized trial. So here the 50 milligram of atenolol versus losartan 50 milligram once a day was compared, and the dose was increased up to 100 milligram with a follow-up period of 4 years. So what we noticed that losartan group showed a significant reduction in the total mortality, stroke, and new onset diabetes. And losartan was very well tolerated. And rate of recurrent MI remained same in both the groups. So this is one trial where the ARB losartan was shown that it is quite efficacious in preventing the reducing the total mortality, stroke, and new onset of diabetes. Next. Then LIFE diabetic subset, like those patients who had besides hypertension and LVS, they also had diabetes. So 1,195 patients had diabetes as well in LIFE diabetic subset. So again, here the losartan was associated with significant risk reduction as far as the mortality, MI, and stroke was concerned. So LIFE was one trial which showed that losartan is quite efficacious in comparison to atenolol. Next, in beta. Now, if you see the meta-analysis between the ACE inhibitors and ARBs, what we in this slide you can see that ACE inhibitor were compared with the ARBs for all-cause mortality, cardiovascular deaths, and cardiovascular events in patients who had diabetes. So in this meta-analysis, hypertensive patients are not necessarily that all the patients who were enrolled were hypertensive, but they were all diabetics. So overall, 35 studies were enrolled in this meta-analysis, and only those trials were enrolled where at least an observation period of at least 12 months was there. So total of like 22 trials on ACE inhibitors and 13 trials on the ARBs were included in this meta-analysis in patients with diabetes. Okay, next. So what you notice over here, ACE inhibitors are associated with significant reduction in the all-cause mortality, cardiovascular death, myocardial infarction, heart failure, and major CV events. But that's not the case with the ARBs. ARBs definitely reduce significantly the heart failure event, but other parameters were not significantly reduced by the use of ARBs. So this meta-analysis in diabetic subset shows that ACE inhibitors are superior because they reduce the all-cause mortality, CV mortality, and major cardiovascular events, whereas ARBs had no beneficial effect on mortality and major cardiovascular events, except for the heart failure. Now, if you include the hypertensive patients, diabetic patients who also have hypertension, and then you go for the meta-analysis. So again, the other things were common. At least 12 months follow-up was required. 13 studies were included in this meta-analysis, 5 with the ACE inhibitors and 8 with the ARBs. And the results were next, please. Again, similar results were seen that ACE inhibitor use was associated with improvement in all the parameters, be it the all-cause mortality, CV death, MI, stroke, heart failure, cardiovascular events. They were all odds ratio are very fine. And if you see the upper limit of 95% confidence interval for ACE inhibitors, it's always below 1. But that's not the case with the ARBs. So with ARBs, either the neutrality was there or there was increased risk of certain parameters. So that is how the ARBs did not fare as well as the ACE inhibitors performed in this meta-analysis. So be it in the diabetic subset or be it in the diabetic with hypertensive subset, clearly the meta-analysis shows that ACE inhibitors are much better, provide much better outcome than the ARBs provide. Next, please. So meta-analysis, comparison of ACE and ARBs on CV outcomes in hypertensive patients with diabetes. You can conclude that ACE inhibitors show a significant cardiovascular protection for all-cause mortality, cardiovascular death, major cardiovascular events, while ARBs had no benefits on these outcomes except for the myocardial infarction. So that is how we have a very clear verdict in favor of the ACE inhibitors over ARBs as far as the high-risk patients or maybe stable coronary artery disease patients with hypertension, with diabetes, or without hypertension with diabetes are each concerned. Next, please. So key message from these trials, what we have discussed till now is that the hypertension and obesity increases the risk of vascular complications, no doubt. In view of differential benefits on mortality and morbidity, the ACE inhibitors appear preferable to ARBs for patients with hypertension and diabetes. The benefits of ACE inhibitors, without any doubt, are consistent, and ACE inhibitors should be the first choice intervention for primary prevention of diabetic kidney disease as well. Next, please. So this is all about the whatever the major trials we had as far as the reduction of the cardiovascular events are concerned. So maybe we can just involve the panel and we can start with the Dr. Amrish. What is the dose that you would suggest for high-risk patients for anti-atherosclerotic properties and for preventing plaque rupture? Dr. Amrish, please.
Yeah, sir. Based on the trials and till now evidence, I would prefer to give in maximum tolerable doses up to 10 milligrams ramipril.
Yeah.
Because sometimes if potassium is high, or if that creatinine is not allowing, then we can reduce the dose. Otherwise, maximum because this property is in dose dependent manner, so we should prefer 10 milligram ramipril. Till if there is any complication or contraindication, then we can reduce the drug and doses.
So, okay, Dr. Amrish. So maybe we can have some comment from other panelists also. Is there any difference of opinion or like the same, or how do you start the dosage? Like, do you go ahead with the 10 milligram directly, or you start with a low dose and then you up titrate? So maybe we can have a comment from Dr. Anshuman.
Yes, good evening, sir.
Good evening.
Actually, sir, when the patient comes to the emergency, most of the patients we see they are in heart failure or MI, there is in late presentation, who have a borderline blood pressure of near about 100, 110. In such patients, we start initially with a very low dose, like 1.25 milligram. Then we gradually escalate it after 2, 3 days when the patient tolerability increases to 2.5, then 5, and then 10. Suddenly increasing to 10 in such patients cause hypotension. So we gradually increase it, and I think that gradually increase patient also tolerates that doses well, and that is way too helpful for those patients.
Yeah, so exactly. So like in emergency situations or post-MI patients where the hemodynamic instability maybe there, is always better to start with a lower dose and up titrate. But what about like if you see patient, because what we are talking about the HOPE and Europa studies, so they were like into not into the patients who had hemodynamic instability or those who had myocardial infarction. So it was like a more of a broad spectrum population what was included in these studies, and majority of them were like outdoor patients. Okay, not majority, in fact everyone was stable patients. So if you find that the pressure is on the higher side, say around 160 by 90, so still you would like to start with the low dose, or maybe you can start with a higher dose?
Preferably in such patients, my experience will say that I will start with a 5 milligram dose, then I will gradually up titrate to 10 milligram.
Yeah,
Suddenly increasing to 10 milligrams, sometimes the patient doesn't tolerate that dose.
yes, that's right. And first dose hypotension is also a concern, so maybe to be on the safer side, maybe you can start with a little lower dose and then after 2 weeks. So maybe Dr. Ashok, your comments, please. Dr. Ashok Chahal, Dr. Ganesh.
Yes, I agree with both the speakers that if the hemodynamics and creatinine allows, then I will start with the 5 milligram. But if the hemodynamics is not allowing, hemodynamics is unstable, then I will start with a lower dose and then gradually up titrate.
Hello.
Fine.
Yeah.
Yes, please.
Hello. Yeah. Very good evening, sir. It was a great insight for me about ACE inhibitors and ARVs. Being a surgeon, my patient profile is totally different. I usually operate the post-operative patient bypass valve, but the patient whom I am treating, I never used this much high dose, and I used to start with the low dose and titrate maximum to 5 mg. Then I go for the combination therapy, sir.
So combination therapy with
Calcium channel blockers.
Okay.
Yeah.
So for basically you're talking about the anti-hypertensive efficacy you are talking
Exactly. Sir. And one more thing, sir. I usually prescribe this ACE inhibitors in peripheral arterial disease. I have a good chunk of peripheral arterial patients whom I do peripheral bypasses, and many patients are on medical management with me. I always prescribe ACE inhibitors to them up to 5 milligram. I never use 10 milligram dose.
So any inhibition for you for not using 10
No, it
milligram?
was not inhibition, sir. But most of the patients are doing well on this dose.
But I think our colleagues and panelists will also agree that if you go for 10 milligram,
Yeah,
that will be,
I can, sir. I
yes,
can.
so that will provide
Yeah.
you more
Yes.
stronger block
Exactly.
ACE inhibition, and you will have a
Sir.
better.
Yeah.
Yes,
It's
This is what the data says.
this is what
yeah.
the data says. Yes. So okay. So any other comments from any of the other panelists? So if not, then maybe we can move forward.
Yes.
Yeah. So one very often discussed thing is that ARB-MI paradox, that few of the trials showed that the use of ARB is associated with increased risk of myocardial infarction. And this came from the value trial, which was again in a high-risk patients enrolling a large number of 15,000 patients. So primary endpoint was again the same and everything. So here the valsartan 160 milligram was compared with amlodipine. The primary composite endpoint was same in both the groups, be it the valsartan and amlodipine. But what was the noticeable difference in the value trial was that amlodipine group had a significantly lower incidence of MI, while the use of valsartan was associated with slightly increased risk of myocardial infarction. So that is how this paradox, ARB-MI paradox came into picture, and then it was further studied in many other trials. Next, please. So here is the differentiation. So on the right side, you can see the primary endpoint. So it was neutral, neither favoring valsartan or amlodipine for primary composite endpoint. But if you see the myocardial infarction, it was higher all across with the use of valsartan. And if you see overall, there was a 19% increased risk of fatal and non-fatal MI with the use of valsartan in value trial. So from here, the ARB-MI paradox started. Next, please. And if you see different trials, so 19%, the gray color is the ARB trials, and the green color is, of course, the ACE inhibitor trials. So what we find from with the use of ACE inhibitors, we find there is a 20 to 22% reduction in the risk of myocardial infarction, as is seen in the HOPE and Europa trial. But if you see the gray color diagrams going up, many trials. So 19% was, of course, the value trial, but few smaller trials, IDNT and CHARM alternate, also showed there was a significant increased risk of MI. But subsequently, many other trials showed it's not like that. And ultimately, I think the meta-analysis has put a hold onto this concept that probably MI paradox is not really evident, but still that remains a haunting experience with the ARB, that it can increase the risk of myocardial infarction. Next, please. So how this increased risk of MI happens? So what we discuss, what we know about that ACE inhibitors actually block the production of angiotensin 2, but ARBs block only the AT1 receptors. And we all know that there are different types of AT1 receptors, AT receptors, AT1, 2, 3, and 4. So when you give the ARBs, only AT1 receptor is blocked, but AT2, AT3, and AT4 receptors are not blocked. And what is considered is that AT2 is one receptor which is responsible for actually ventricular hypertrophy, remodeling, and plaque instabilization. Similarly, there is by AT4 receptor, you have increased expression of PAI1, so leading to increased risk of thrombus formation. And then through different these AT2, 3, 4 receptors, you can have increased expression of ABMP, leading to plaque disruption and myocardial infarction. So that is a postulated mechanism how the ARBs increase the risk of myocardial infarction. While that's not the case with the ACE inhibitor, because if you give the ACE inhibitors, all angiotensin 2 receptors 1, 2, 3, 4 are like blocked because it's not produced. And additionally, there is increase in the bradykinesis substance P, leading to further vasodilatation. So that is how the ACE inhibitors probably reduce the risk of myocardial infarction. Next, please. So it's the same thing, ARB-MI paradox, how the risk of myocardial infarction increases because of the angiotensin 2 promotes plaque rupture by augmenting the MMP1 in an AT2 dependent fashion. So AT2 receptor and to some extent AT3 and AT4 also are responsible for ultimately to increase risk of myocardial infarction with the use of ARBs. Next. So this is a meta-analysis published in 2012. So all the green you can see with the ACE inhibitor, there is a reduced risk of global death, cardiovascular death, stroke, and MI with the use of ACE inhibitors. But if you see with the ARBs are very good in reducing the risk of stroke, even better than the ACE inhibitors, as you can see from this meta-analysis also. But there is an increased risk of myocardial infarction with the use of ARBs in this meta-analysis as well. Although there is no impact on the mortality rate with the ARB. So this is also a very important differentiating feature between ACE inhibitor and ARB, that in high risk or low risk subset patients who are at increased risk of cardiovascular events, the ARBs are not associated with the mortality benefit. They reduce the risk of stroke. They more significantly reduce the blood pressure in comparison to ACE inhibitor. but probably there is a non-significant increased risk of myocardial infarction. While ACE inhibitors reduce the mortality, they reduce the stroke, MI, heart failure, and all the primary composite endpoints. Next, please. So we can have a comment from Dr. Anshuman Gupta. What do you feel? ARB-MI paradox, is this a reality or it's a myth? And then in patients with chronic coronary syndrome with hypertension, what will be your choice as an antihypertensive drug, ACE inhibitor or ARB?
So dealing with this first question, that ARB-MI paradox, actually, sir, in reality, what we see that the many patients who are on ARBs, even they don't complain of any MI in the further future. Means the whole patients which I have subset, which we are seeing in the OPDs or in the IPDs, we are starting left and right the ARBs. But still, this whether they increase the risk of MI, I really don't know. This question actually, I was even not able to understand whether they increase or not. But according to the previous trial, like that's a value trial which showed there was a 19% increase. Whether this is a myth or reality, I also don't know. And second, for the second patients with CCS, definitely my first choice is always and always an ACE inhibitor, because as we have seen, as also you have told that in the previous trials also and the meta-analysis, the ACE inhibitors have an overall cardiovascular benefit compared to death, fatal MI, stroke, and overall reduction of all the events.
Yeah, okay. So maybe Dr. Ashok, your
Yes,
comment?
same, sir, same. I agree with Dr. Anshuman.
Right. Any different opinion, Dr. Ganesh, Dr. Ravi?
Not really, sir, but I usually start ACE inhibitor in comparison to ARB, as he mentioned. In my most of the patient at post MI, they are on ACE inhibitors. If there is any say chronic cough, dry cough, then I may shift to ARB. Otherwise, I like to continue with the ACE.
That's correct. So, like in general, we have an opinion that ACE inhibitors are the preferred agents. Okay. As far as I know, that ARB-MI paradox was very talked about discussion in against ARBs in the early period, and many trials, as I have shown, also showed that probably the ARBs increase the risk of myocardial infarction. But subsequently, we had meta-analysis, and it was very clearly shown that there is no risk of increased MI with the use of ARBs. And even in the on-target, which was a very large study and which showed that the ARBs are as effective as ACE inhibitors. So there was also, I think, 7% increased risk of myocardial infarction, but that was non-significant. Ultimately, meta-analysis also showed that probably it's a myth only, and hardly there is an increased risk of myocardial infarction
Yes,
with
sir.
the ARBs. As far as the second part is concerned, like in patients with chronic coronary syndrome with hypertension, what will be your choice as an antihypertensive drug? So I think ACE inhibitor or ARBs will not be a first choice of antihypertensive agent. I will go with the maybe a calcium channel blocker or beta blocker in this situation with the chronic coronary syndrome. And obviously, if a patient is diabetic, then probably I will add it as a first drug or maybe as a second drug. But in chronic coronary syndrome with hypertension, I think beta blockers should be the preferred agent. But amongst the ACE blockers, like of course the ACE inhibitor should be the first drug, and they should be preferred over the ARBs. All right. So any more comments from our learned panelists, or should we move forward?
I think we can move forward, sir.
Okay.
And we can skip the slides, in fact. We can ask them questions.
Yeah. So high risk population, this is about the on-target study. Next. So there were two important trials with on-target and transcend. So on-target was basically telmisartan plus versus placebo, ramipril versus placebo, combined. Tell me with ramipril the efficacy in high-risk population. And the transcend was like in patients who were ACE intolerant. Then telmisartan was given versus placebo. It was a smaller trial and carried out in 5,000 patients, but on target was a very large trial, 25,000 patients, equally divided 3 arms. Okay, so obviously the primary outcome was almost similar as I was telling in our on target, and it was shown that the telmisartan and ramipril are equally efficacious. But of course, combination therapy should not be given because there is an increased risk of angioneurotic edema and adverse renal outcome. So next, please. Trans on target. So this is how in this trial what is written here is that ARB telmisartan was not inferior to the ACE inhibitor for reducing the risk of major cardiovascular events, including cardiovascular deaths. So this was one trial which established the role of ARB, in fact. And ARB achieved a lower blood pressure than ACE inhibitor, but there was a 7% increased risk of MI even in this trial also, although it was non-significant. So that is how the on-target study showed that ARB. So different people take it differently. So proponents of ACE inhibitors, they say that ARB was not superior, but proponents of ARB, they say that ARB was as efficacious as ACE inhibitors in reducing and in fact, there was a better control of the blood pressure. So that is the thing. Next is a Transcend trial, of course. So it was a telmisartan versus placebo in patients who were not tolerant to the ACE inhibitors. But again, here the telmisartan was not effective. In fact, it was just as good as placebo in reducing the cardiovascular event. But there were multiple drawbacks about this trial, a small number of patients, and probably the majority of these patients were on the ACE inhibitors initially. So legacy effect, what you call, or HOPE study, what you have seen, HOPE 2, like extension study. So still the ACE inhibitor was beneficial. So probably this is one trial which was with some fallacies, of course. So Transcend showed that the use of ARB was as good or as bad as the placebo. Next, please. So Dr. Ashok, so here is a question for you. Combination therapy is preferred over monotherapy for hypertension. How can we reach the maximum dose as suggested by key trials to obtain maximum CV benefits? HOPE trial, ramipril 10 milligram, on target telmisartan 80 milligram. Are we practically using these monotherapy doses?
No, I'm not using this kind of these high doses, sir. I'm mostly using combination therapy, and I never prescribe this 10 mg ramipril to any patient. Maybe I'm having a different kind of patients. The most patients are post-operative bypass patients.
Yes.
And yeah.
Okay. So as you have already mentioned about that, you stick up to the 5 milligram of ramipril, and then you switch over to.
Yes.
Okay. So what is the opinion
combination
from the other cardiologists here?
Yeah, we start ramipril and goes up to 10 milligram. Then if blood pressure is not controlled, then we add on the drugs. Well, first we would prefer the monotherapy, ramipril, and go up to 10 milligram.
So you go for a step care approach. One drug is to the full extent, and then if it is not efficacious, then maybe you will add the other drug.
A patient is having dyspnea or diastolic dysfunction, then we can add on initially with diuretics.
Okay. So Dr. Amresh, any comments from your side?
Yeah, I am telling. I am.
Okay.
Okay.
Dr. Anshuman? Any other comments from panelists, co-panelists?
What I think that baseline BP also dictate how much drug you want.
Yeah, definitely, yes. I agree with that.
If the baseline BP is more than 160, in my opinion, combination therapy is preferable.
So
ACE inhibitor with the doses of 5 milligram with the low dose of diuretic, I usually prefer that, and I usually start with that. If
so
the
no
BP
doubt
is not
about
controlled,
this. Stage 2 hypertension, if you have, I think monotherapy may not be efficacious, and it's always preferable to have a smaller dose of 2 drugs than going on with one drug and to the highest, because then the side effects are reduced, and then you have a synergistic action also. So agreed, if you have stage 2 hypertension, it's always better. ARBs are very good drugs. ARBs have a more powerful impact on the blood pressure, no doubt about that. And if you combine the ACE with low dose of diuretics, especially the thiazide diuretics, so you have a much more efficacious power in your hand, this synergistic action. And even 2 drug or even 3 drug with the calcium channel blocker also you recommended. if the things do not improve before going for the highest dosage with one monotherapy. So that is what the recommendation is also there. But
That actually I wanted to say.
yeah. But one thing is sure that in patients where the indication for ACE inhibitor is there, like in post-MI patients with heart failure, LV dysfunction, diabetic patient, albuminuria DKD. So the other patients where the maximum tolerated dose of these drugs should be given. And maybe like nowadays in heart failure, you prefer for ARNI, but wherever the scope is there in post-MI patient especially, so still we have data because ARNI is not as effective in the immediate post-MI period.
Yes.
Impact MI and DAPA-MI were not very positive trials. So obviously in those situations, the ACE inhibitor should be given to the maximum dose and preferably to 10 milligram ramipril if possible. Yeah. So can we have the next slide, please? So here is one question for Dr. Ganesh.
Yes, sir.
Is merely reaching the target or goal BP important? Or selecting the right antihypertensive agent too should be considered, especially in patients with comorbidities like CAD?
Obviously, the answer is no. It is not just reaching on the targets. It is not the number you want to achieve. You want to lower down the cardiovascular risk. And not only the comorbidity like CAD, whereas other factors also govern the choice of antibiotics, choice of antihypertensives. Like in young patients, even the beta blockers can do wonders. And then in diabetics, obviously, we have studied a lot that ACE inhibitor is good. In CAD, ACE inhibitor is good. In heart failure, ACE inhibitor is good. And you can add ARNI if required. And then in cerebrovascular disease, ACE inhibitor has also shown the good results. In pregnancy, then methyl dopa and beta blockers, then amlodipine, CCBs are required. Then elderly, then CCBs and ACE inhibitors are required. In COPD, where you can't give beta blockers, then ACE inhibitor and amlodipine is good. Then in dyslipidemic patients, where you don't want to give diuretics as well as beta blockers, then again ACE inhibitors and CCBs are good. So the treatment should be individualized. It's not like that one drug can fit all the comorbidities or all the individuals.
Exactly. Absolutely right. So basically, management of hypertension is not that you can prescribe one drug. Every patient's condition, comorbidity, hypertension level has to be taken into consideration, and accordingly, you have to proceed as you have already mentioned about all the parameters. So absolutely agreed with you. Can we have the next question, please? Yeah, so here is a question for Dr. Ravi.
Yes, sir.
What is your perspective on the clinical evidence comparing ACE inhibitors and ARBs in the management of hypertension in patients with diabetes? That is the one question. And do you believe one class is superior to the other by improving long-term outcomes?
Yes, sir. Just now you pointed out, sir, the meta-analysis of trials wherein ACE inhibitors and ARBs are compared, and ACE inhibitors fared better than ARBs, and in fact ARBs increased the risk of myocardial infarction, and that is MI paradox also you mentioned, sir. So ACE inhibitors are better choice than ARBs in the management of hypertension with diabetes, sir.
Yeah, absolutely.
So obviously, ACE inhibitors is superior. ACE inhibitors are superior in the long term also, because the trials also went up to 4.5 to 5 years, sir.
Yes, yes, yes. So any other comment from any co-panelist on this question?
I think
It is
we are
actually the theme which we are discussing.
Yeah, that's true. And in fact, if you see all the major guidelines also, everywhere you will find that the ACE inhibitors are the preferred agents for maybe, forget about the hypertension, but all other conditions. ACE inhibitors are the major first class 1A recommendation, be it heart failure, be it post-MI. And what they said, ARB, only when ACE inhibitors are not tolerated. So especially like angionotic edema is not very common in our society, but cough is really distressing. So we very often see the dry cough with the use of ACE inhibitors, which leads to discontinuation in almost 10% of the patients, you can say. And they usually do fairly well with the whenever we change from ACE inhibitors to ARB. So no doubt the data is more in favor of ACE inhibitors in the high risk subset, and as has been demonstrated by a good number of trials also. So that is what the opinion is from the house as well. So
Yes, sir.
is it the last question or we have some more questions? Next, please. So there is another question for Dr. Amrish. How do you weigh the renal protective benefit of ACE inhibitors versus ARB in diabetic patients, especially in those with diabetic nephropathy?
I think ACE inhibitor is protective mechanism in diabetic nephropathy, but we have to start at lowest doses, and we have to monitor the creatinine level too. If any jump in creatinine level, we have to stop the ACE inhibitors.
Yeah. But in diabetic nephropathy, they are still recommended.
Yes.
And IDNT and renal were the trial with the ARBs, of course. And if you remember, they improved the renal outcomes, but they did not improve the vascular outcome, either in IDNT or renal. So it's still like we often leave it to the nephrologist friend to decide what to be done. But yes, diabetic nephropathy one subset, especially the proteinuric diabetic nephropathy, where I think the ACE inhibitors or ARBs should be given. So next, Dr. Anshuman, for you, there is a question. In patients with chronic coronary syndrome with hypertension, what will be your choice as an antihypertensive drug? I think this question we have already discussed.
Yes, sir.
I think this was the question earlier also. So there is another question for Dr. Ashok. Is ARB, which would be your preferred choice for long-term CV benefits?
Yeah, definitely ACE inhibitor.
Yeah, I think so. There is no confusion about this question.
Yeah.
And we have seen and many other trials also progress, profess, and stroke and other things also. So we have seen not only into the cardiac endpoint, but also in the cerebrovascular endpoints also we have good number of trials. And even in the peripheral arterial disease also, as Dr. Ganesh was highlighting. So of course, I think this is the preferred agent ACE inhibitor. And only if the ACE inhibitors are not tolerated, then I think the ARB should be the next choice. Next, please. So before we conclude, maybe we can have a final comment from all dear friends who have joined over here, and then maybe we can take up the questions from the audience also if there is any queries. So I will request the team MQR to just. Yeah, so first let me have a comment from Dr. Amrish.
Yeah, that's a very good discussion and very informative. Sir, for elaborating these nice trials. And in final comment, I think in ACE inhibitor is definitely with the different trials and meta-analysis, I think in many aspects, ACE inhibitors is better. And as you previously said, in guidelines also start ACE inhibitors first. If intolerable, then you can switch over the ARBs. So I think I practice in the same way. I start ACE inhibitor first. If any not tolerable, then we can switch over to ARBs.
Correct. Dr. Anshuman, your comments, please.
Yes, sir. Dr. Anshuman is not there.
Okay.
He got one case for.
Okay. So Dr. Ashok Chahal, your comments. I think.
Yeah, he's not there, sir.
Okay. Dr. Ganesh.
What I can say that the extensive elaboration by you that ACE inhibitor is obviously beneficial. In my opinion, I too usually want to start with the ACE, but many situation there is I start with the ARBs, and patients are really doing fine on ARB. There is no problem on that. And especially in the patient with the heart failure and MI, I try to start with the ACE, but pure hypertension without CAD, without MI, without diabetes, I often start with the ARB, and patients are doing fine.
So that's true also. In fact, if you see the anti-hypertensive efficacy of ARB is somewhat better than the ACE inhibitor, no doubt about that.
Yes. Yes.
And in isolated hypertension, I think there is no criteria that only ACE inhibitor to be tried first. ARBs can be used very safely. But in subset of patients where you need plaque stabilization, where you need the arterial remodeling to be in a better way, and its consequences, of course. So I think in high risk population, in low risk population with CAD, like in Europa. So obviously, if patient has CAD, or he has a peripheral arterial disease or maybe other vascular abnormal trees involved, then definitely I think the ACE inhibitor should be preferred choice. In diabetic subset, I think if you are using the drug, then the ACE inhibitor should be the preferred choice. Diabetic with hypertensive, also ACE inhibitor should be the preferred choice. Patients with post-myocardial infarction, patients with LV dysfunction, these are the subsets, patients with heart failure, they are subset where the ACE inhibitor should be the preferred choice over ARB, no doubt. Isolated hypertension, not a high-risk patient, younger population, I think ARBs could be as good as ACE inhibitors, no doubt about that. So Dr. Ravi is also, I think, is there?
Left.
He left, I think. So any questions from the audience side?
Yes, sir. So actually, there's one interesting question. Like I think one you mentioned to use the beta blockers into the young patients. So there's one. How do you see the role of the AS plus or ARB plus beta blocker combination in the young patient who have the comorbid conditions? So do you like to use beta blockers in combination in those patients, or you like to go ahead with the monotherapy of the ACE or ARBs?
It all depends upon the comorbid conditions, the magnitude of hypertension, that actually dictates. But antihypertensive efficacy of beta blockers are not very pronounced. So usually it's not a preferred agent as far as the antihypertensive efficacy is concerned. So you have better options with the ACE, ARBs, and of course the calcium channel blockers and the thiazide diuretics. So they are the preferred agents. But yes, if there is an indication, suppose he has a coronary artery disease, and where you need to use the beta blocker, then that's a different unexplained tachycardia, a lot of anxiety patients. Sometimes you see the younger population, so that's maybe different. So comorbid conditions will explain and will, of course, dictate whether you need to use the beta blockers. Otherwise, many other classes of drugs are available for use in these subset of patients.
Okay, great. Thank you, sir. So I think, sir, it is 9, so we won't take much of your time because we are already past our time. So,
Okay.
but again, it has been really wonderful session what today, based on the hypertension and diabetes patient profile, which wants to use ARB or ACE. So definitely we have our set of opinions. So in the comments, of course, the ACE scores over better ARBs, but of course that needs to be individualized according to the patient, what we discussed today, sir. So
No
thank you very much, sir, Dr. Santo S.K. Agrawal, sir, for your beautifully moderating today's session along with our great panelists, Dr. Ambrish sir, Ganesh sir, and of course, the rest who are left. So, but great, sir. Thank you so much for your time, sir.
So it was
Thank
nice
you.
meeting each one of you, and it was a really useful discussion we had today. And I hope it will improve our clinical practice also and patients' outcome. So thank you so very much, my dear friends. Good night. Have a nice time. Bye-bye.
Thank you.
Right.
Thank you,
Thank
sir.
you so much,
Bye-bye, sir.
Bye, sir.
Have a great, sir. Bye.
Okay.
Mankishore, we can stop the streaming.
Recording.
Yeah, and recording as
Yeah.
Yes, sir. Stop.
well.
बढ़िया ना लगभग 220 230 करीब है
हाँ,
क्योंकि